but she has explained it very nicely. And any question in front, you can ask afterwards. Now our next speaker, Dr. Kushani.
Good morning, very good morning friends, and this has been such a pleasure to be here. Your campus is super. For Bombayites, this space is unknown almost. So I thank Dr. Dasgupta and Dr. Chatterjee for being so benevolent to me. While I was going today to have my breakfast in the morning, I saw the banner of this conference. It was Safe, Anesthesia and New Horizons. Trust me, this is the most apt workshop under that banner. Ultrasound precisely is doing that. It's making regional anesthesia far more safer and opening new horizons into it. If you have heard Mamta's lecture, she's probably voicing the same. Well, my job is to take care of upper extremity blocks and lower extremity blocks. I am aware that we are short of time. I shall try my best to throw my thoughts at you all, and then we'll get going with the workshops. Well, we get on with the upper extremity blocks. As she just said, our concerns have been intravascular injections with the traditional modalities, intraneural injections, because we got paresthesia, so this means we were very, very close to the axons, injury to any structure close to the nerve, which we don't intend to injure, but we do because we don't see, and block failures. It's not so theatrical as the other three that I have mentioned, especially the intravascular one. You will either have your patient convulsing in front of you, or you will either have your ECG giving you broad QRS complex resistant to treatment. But this particular point, the last point that I'm talking to you about, block failures, is a complication which an anesthetist has to digest. If your block fails after giving it with a lot of patience and care, something in you fails. The confidence in the subject keeps going down. And hence we all thought that how do we get this art, which was mastered by few, into a science, into practical logistics steps, and then getting the failures minimized and increasing the efficacy. How did we do it? How do we achieve it? So came our thought of seeing the nerve and seeing the structures, and that's what now we are going to do. This is like, how we have had laryngoscopes for putting in a tube through the vocal cords. We saw them. How difficult it would have been if we were to do it blindly all the time. But blind nasal intubations or blindly with any kind of intubations are known to us. If we pick up a laryngoscope. So the concept is so very easy, but for a long time we have been debating whether ultrasound should be handled by an anesthetist. Is it needed? And I'm so glad that the administration is also here to hear what I am saying, and they are anesthesiologists, so it's a great advantage for your hospital. Because we are making such big strides in regional anesthesia today, any complicated patient with an upper extremity block can be now taken very safely in the theatre and not taken to the ICU post-op. In fact, it could be just circumvented. Well, so having said this much, I must also tell you the flip side. The flip side is the mind always wants or sees what it already knows. Hence, it's very important to us to get into the depth of this subject and get geared. What I mean here is, you are going to see maybe an old haggard woman here, if you wish to, with a fat nose and a drooping chin, and this is her mouth. If you wish to see, you can also see a very young woman with this kind of a fur cap, with her eyelashes, and this is her chin area, and this is her dainty neck. So it all depends upon how you are going to digest the subject, and hence again this gathering. Well, the upper extremity blocks, as we all know, practicing anesthesiologist, we need not really go into details of the anatomy here. It's trunks, divisions, cords and terminal branches. I have read this because this is what we are going to look into once we start the blocks. Let's go to the first block, that is the interscaling block. So an interscaling is a beautiful block in the sense it's akin to a spinal. It can be that dense and it can act in a jiffy. That's because here the axonal components are more. It gets going very fast, unlike an axillary or an infraclavicular where the soakage time is far more. Okay. What you can take care with an interscaling block is the shoulder. It's a perfect block for shoulder and proximal humeruses. The more distal you go with the surgical side, the more distal you go with the brachial plexus divisions too. Well, if once you keep the probe on the neck, you need to see very few structures here, and they are the anterior scalene, the medial scalene, the brachial plexus. Okay, so these are the few structures that you really need to see. Only three, 1, 2 and 3, 2 scalenes and 1 brachial plexus, that is one on each other trunks. Well, to see what I just said, the probe is kept like this. This will be elaborated to you when you meet us on the workstations. And mind you, any block that can be performed in adults, yes I meant any, can be given in a neonate. Any. We have given interscalenes or we've kept intraclavicular catheters for ischemic hands and we've gotten good results because it also performs as a sympathetic block. Luckily for us, nature has intertwined sympathetics and somatics in upper extremity. Well, so this is how the probe is kept and this is how the needle is advanced. Having kept the probe this way, what we see on the ultrasound screen is this. These are the 2 scaleni, as I told you. This is the brachial plexus. Now, to understand this, I need to explain that this is the transverse section of the neck. This is the anterior portion of the neck. This is the posterior portion of the neck. The depth is around 4 centimeters here. I could have reduced it and made it even a better image. And this is an orientation marker which is going to tell you which is the right side of the patient and which is the left side of the patient. If we don't know the orientation marker and if we have not drilled ourselves towards it, what probably would happen is we might get confused as to which side is where in the scan in relation to the body of the patient and how to advance the needle. Okay, so orientation marker is a must to know. If not the marker, at least the fact that you can tap on the probe and see where what is moving. Don't get very flummoxed. We will clear it up when you come to ask for stations. So this is the needle that has advanced. These are the trunks sitting here. And now that you see the needle right here, we are going to deposit the drug and get our block. It might sound very easy when I am saying it, but obviously it has a learning curve. We need to go through it with patience, but once we have mastered it, we master the entire block. Do you want to ask me something? The person sitting at the back, can you raise the hands? Doctor, you want to ask a question? Okay. So this is one, just an example, a very bad chest and has a rod kept in. We had put in a rod also in the humerus under a block and removal is also done under a block. If you want to do it with any other techniques, the anatomical landmarks are totally gone. So this is the best way to work here. Sedate your patients if you think that it is really very difficult to him to digest a needle, because that's one of the fears everybody has. Give ketamine, midazolam, or just give ketamine or give midazolam plus fentanyl so that they don't really get worried with the block. Then give the block. But obviously even a well-placed block is going to give you some issues. Surgery will go on, the patient is staring at you and might then suddenly say that her voice is going down. At this time, as an anesthesiologist, if you know that this is recurrent laryngeal nerve, which is now gotten into the local effect, You just have to reassure them that it will come back. One thing that will open up to you after having practiced neck blocks is, no matter how precise you are in your drug placement, you will get your block for sure, but then it will be opened up that, look, neck is not a watertight compartment. After some time or the other, the drug might trickle here and there through the facial planes and might attack nerves which we did not intend to. The most common nerves here in the neck is the phrenic and the recurrent laryngeal. Okay? But again, having some tricks of the trade, like not taking the needle in between the two trunks, keeping it more lateral towards it, and then having your drug spread here in that, probably will not make the drug flow as much towards the phrenic and the recurrent laryngeal. To really sense what I am saying, we need to experience what it is to give an ultrasound guided block with this approach. Well, let me go to the next slide. Any spot diagnosis? Ptosis after interscalene block? Okay. Well, this is another person here with a fractured humerus who's come. Landmarks are difficult, but keep a probe, you'll be able to see. Again, fatty tissues also look like, those onion rings, which the nerve looks like it. But then anchor it around the subclavian artery. Take the probe up. Luckily, again, nature has been kind with upper extremity. The vasculature and the brachial plexus, they move together. Whenever there is a confusion between identification, go to the subclavian, see the subclavian, then you will be able to locate the brachial plexus around the subclavian. Once you have located the brachial plexus, just sweep the probe up and you're going to get your interscalene block. Because they all are a bundle of noodles, walking from the neck towards the axilla. And they're so interlinked with the arteries. Alright? So this was her scan, in fact, not as bad as I had expected. This is the brachial plexus and this is my needle which has come here. We're coming to supraclavicular. Supraclavicular is a good block for distal humerus, even to some extent the elbow. In my practice, elbows I always do with a dual block, one above the clavicle and one below the clavicle, because elbow is a very grey